Hello, and thank you for joining us on this special topic of cervicogenic dizziness and what role the cervical spine plays. My name is Dr. Stephen Spinks. I'm with the American Institute of Balance. I'm the Vice President of Clinical Services and Research. My background really is in outpatient orthopedic physical therapy with a specialization in manual or hands-on therapy. Born out of necessity in a small town in East Tennessee, I decided to expand my services to the vestibular world. And having taken multiple courses over the years and doing some just internalized studying, I decided to really specialize in the vestibular component as I saw the need for patients, especially in small rural towns. Where this combination came from, though, was the utilization of hands-on or orthopedic components with dizziness, and that's really where the cervicogenic dizziness plays a role. So one question a lot of therapists have after they've ruled out any inner ear dysfunction, it usually falls down to, okay, what else is this? What else could this be? And for this, we can focus on one of the key driving factors for dizziness, especially internalized sensation of dizziness, and that's where the neck comes in, and what's coined as cervicogenic dizziness. So really, how do we define cervical dizziness or cervicogenic dizziness? One example of a definition from Furman and Cass is a non-specific sensation of altered orientation in space and disequilibrium originating from abnormal afferent activity from the neck. I want to take a little minute and delve into this definition because there are a few key factors in this that still resonate true. It's non-specific. These patients may report lightheadedness, heavy-headedness, internalized dizziness, or disequilibrium. Rarely do they report true world-spinning, vertiginous complaints. That's not to mention that they're mutually exclusive, in that traditionally we see this following a head injury or a motor vehicle accident where the patient has this spasm pain cycle or guarding of their head and neck, but also something to have elicited dislocation of the otoconia in the inner ear. And so they may have secondary BPPV, benign paroxysmal positional vertigo, with their primary insult being neck pain and dizziness originating from the neck. The second key point to look at is this sensation of altered orientation in space. As we'll delve a little bit deeper into the mechanics of this, we'll note that there are special receptors within the neck that tell us where our head and neck is at in space. And so there may be abnormal input from those receptors going to the brain, causing this misinformation in the processing unit. As you've probably seen in multiple research papers, books, and other presentations, the vestibular system is not a very simple schematic. Oftentimes, there's more input than there is output, or depending on the patient in front of you, there may be less input and more output. And it's that misinformation that causes this sensation of dizziness and disequilibrium. In this, we have a few examples of the peripheral vestibular system, cervical proprioception, vision. We can also take into account the external component for the vestibular spinal reflex, bringing in information to our processing unit, which we'll just call the central vestibular system. And we can see the output that's coming from that, whether it's ocular motor function, the VOR, balance function, perception of where we're at in space. We can see it's not just an easy picture to paint, and that's why when we're going through our vestibular assessment and workups, we're looking at each key factor that can play a role in the brain's perception of balance in space. So let's take a little dive into some of the incidence, prevalence, and really the general complaints related to this population. Over 2 million visits occur to the emergency departments in the United States alone with complaints of quote-unquote dizziness and or vertigo. It's estimated that at about 7.5% of those patients, the neck may be the most contributing factor to this. Unfortunately, though, we have no gold standard tests to help rule this in, or rule it out really. And as we'll learn, special tests aren't quote-unquote special, but the literature backing them can be really beneficial in helping us rule in or rule out objective measures to help guide our treatment plan and protocols with these patients. Most of the literature that you'll find for cervicogenic dizziness is related to whiplash-associated disorder. Remember, this is more of an umbrella term as it relates to neck pain following an injury. But within that, about 20 to 60%, again, you can see the numbers are a little varied on this because the literature is not great, between 20 to 60% of those patients experiencing true vertiginous complaints, dizziness, and disequilibrium. And obviously the top factor with them is neck pain. Some of the common subjective and objective components found for patients with cervicogenic dizziness are just what I was speaking about, the associated neck pain and concomitant limitations in cervical range of motion. Traditionally, its rotation is most limited, followed by extension, then flexion, and lastly, cervical side bending. Those limitations are also tied in with the patient's complaints of dizziness. So most patients feel it with rotation. And this is going to be a key factor when we get to some of our differential diagnoses of ruling in or ruling out the vestibular system as being the driving factor for the patient's internalized dizziness, or is it the neck? Second, we have impaired postural control and sensory motor dysfunction. We do have a pretty great test that we can use in the clinic with this. It's the low-tech, no-tech version, and it can help rule in the fact that the neck may be providing disinformation or misinformation to the brain as to where it's at in space. Thirdly, we have ocular motor dysfunction or smooth pursuit deficits. Spontaneous or positional nystagmus is really tied in to more of an acute injury that is mostly seen by my PTs and OTs in the emergency department. This patient may have a newly acquired history of falls and a subjective feeling of uneasiness and unsteadiness. Alright, so let's take a peek at some of the causative hypotheses behind cervicogenic dizziness. The first one, the neurovascular hypothesis, is more of a mechanical rationale and hypothesis. As we know, the vertebral arteries run cephalad towards the brain. They eventually connect together at the basilar artery and then again bisect into the circle of Willis. Just between the basilar artery and the circle of Willis, there's a small little projection, and that's the AICA, anterior inferior cerebellar artery. I have to say that one slowly, I usually slur it. That little artery then creates a microvascularization into the inner ear and subsequently the vestibular system. The hypothesis behind this is that any mechanical compression to this artery can reduce blood flow to the vestibular system, thereby creating an altered output from the vestibular system to the brain. While this has not been disproven, it's a little bit more on the back burner as the somatosensory input has had a wealth of literature poured out looking at these little fine nerves and collection of nerves within the upper cervical spine and how they play a role in telling us where the head and neck is at in space. One of the key comments behind this is the thought of if you don't move it, you lose it, or if there's any type of localized injury to the area, that these proprioceptors may be not putting out the best information to the brain. And so one of the causative things that we can think about are MOIs, the mechanism of injury or onset, is really post BPPV. I've seen it multiple times in the clinic, is following BPPV, but most patients are told don't move your neck, don't move your neck. And so they're not moving their head and neck for weeks at a time. Well, if you're not stimulating those mechanoreceptors, the information that's being put out by them is pretty poor. Luckily though, the sooner we can catch on to this, the faster the patient can rehab. It's quite remarkable. Don't worry, this isn't going to be a neuroanatomy lesson, but we do want to cover just at least a few of these vestibular and spinal reflexes. The top two we're really going to focus on are the cervico-ocular reflex and the cervicocolic reflex, especially as they play a role in the input and output of the neck to the brain to the inner ear and the resultant sensation that is associated with them. Remembering that the cervico-ocular reflex is driven by those proprioceptors in the cervical spine, and then also the cervicocolic reflex is related to a stretch reflex, really more so for the riding of head position. But where this plays a role is that if those muscles have undergone a strain, counterstrain, or a stretch reflex, and they've quote-unquote spasmed from a localized injury or reduction in motion because of fear and or BPPV, these patients may have an abnormal component to the COR or the CCR. Here we see some of the more advanced inputs and outputs related to dizziness and unsteadiness. This is by Dr. Trevelyan. Obviously, most of us in the PT world, especially as it relates to anything for neck and dizziness, know her name. While this looks like a busy slide, it's actually pretty interesting to see the different components of postural stability, head movement, eye movement, and how all the reflexes play a role in producing both upper and lower extremity maintenance of upright systems, and also how the neck and the eyes are all connected. Here are just some examples of some of the signs and symptoms associated with vertebral artery insufficiency, whether it's related to ischemic changes or non-ischemic changes. One thing we want to touch base on is the fact that the neck before ischemic changes may demonstrate just traditional posterior lateral neck pain or occipital headaches. And so patients who have a non-mechanical or something that can be palpated neck pain may raise some red flag issues, especially once you start to add in the ischemic changes in that left column. The internal carotid artery also has some ischemic and non-ischemic changes. These are really more related to retinal changes as we get into non-ischemic and ischemic changes. And so paying close attention to any visual disturbances associated with anterolateral neck pain, usually along the SCM, which is traditionally a muscle that's not too happy following a motor vehicle accident or a whiplash-associated disorder. For our patient who presents with neck pain and dizziness, there are some red flag screening tests that we can run through when addressing upper cervical instability. That's the sharp purser test, the alar ligament stress test, and the transverse ligament test. Alright, so here we have a series of cervicogenic dizziness tests. In this one, we're going to cover the head-neck differentiation test. This one and the next one are very similar in the body positioning. So for this one, the patient's going to be seated, feet on the ground, preferably on the edge of a plinth or in a chair with a backing. I'm not a big fan of the stool picture right here, but it does make it easier for the patient to rotate their body. You as the practitioner are going to support their head and neck in a neck neutral position and have the patient rotate their body to one side and then to the other. The reason behind this is if the patient subjectively reports, I turn my head to the left and I get dizzy, well, we don't know if it's the neck rotating that's causing the dizziness or they're just stimulating their vestibular system by rotating their head to the left or right. So we can take out the vestibular system by having no acceleration of the inner ear, keeping their head neutral, and just having them rotate their body. If now they do this and they still report dizziness, it helps rule out the vestibular system and add a little extra bump into the ruling in of the neck being the causative factor for this. Following up with that, with the exact same body positioning, now we're just going to add in smooth pursuits. So, doing smooth pursuits in a neck neutral position and then having the patient keep their head still, have them rotate their body, and then reassess smooth pursuits. Remember, this places the cervical proprioceptors active, vestibular inactive. In this, there actually is some literature supporting this for a high specificity, specifically for patients following whiplash. But this is always good to add into your day-to-day regimen. Remember, as part of your VOMS assessment, you've already done smooth pursuits. Now we're just adding in the body rotation on neck neutral. So what are some treatment approaches we have for cervicogenic dizziness? Whitney, Furman, Risley et al. Came up with some really good information regarding just an overview of some of the evidence. Unfortunately, it's level 3 evidence at best, meaning that there is support of use of exercises in hands-on treatment. But just like most of the PT journals out there, exercise plus manual therapy is better than exercise alone or manual therapy alone. Really, it's that therapeutic alliance you're building with your patient, whether it's hands-on, but primarily it's mostly education. Educate the patient on the fact that moving their head and neck is not bad for them, and that introduction of movement patterns is going to be beneficial for them. That's why actually a lot of VOR exercises, even though this may not be a vestibular issue, is beneficial for them because that involves head, neck, eye stabilization, which in reality, you're moving the head and neck. It works out really well with this. And so you can add in small strength training, because remember, you can't go wrong getting strong. So strengthening of either the longus colli for the deep neck flexors or of just overall biofeedback, and using a laser pointer to go through and maintain a stable, steady image as the patient is performing their exercises. A lot of times my therapists always ask, well, what are some hands-on techniques that we can use with these patients? Great articles out there looking at SNAGs, NAGs, so Brian Mulligan versus Maitland approach. There are also some other cervical manipulation articles out there, all of which were beneficial for these patients, specifically designed towards the upper cervical spine. Remember that all of these need to be followed up, though, with some deep neck flexor or DNF retraining and cervical proprioception retraining. Thanks again for joining us on this quick little overview of cervicogenic dizziness and how the patients you may see in the clinic with neck pain may actually have some dizziness related to their neck, and it might not just be their inner ear. Making sure to address all components of the patient's history, past medical history, looking at their mechanism of injury or onset, and some of the subjective objective measures associated with cervicogenic dizziness. If you'd like to learn more, visit dizzy.com/workshops or read Dr. Gans's blog.